Hi, and welcome to the Women's Handbook podcast, How to Be a Woman, where we talk about everything women's health from menarche to matriarchy. I'm your host, Dr. Natalie Hutchins, and today I'm talking to Professor Huang. He's a clinician scientist at the National University of Singapore with a special interest in fertility, assisted reproduction, and reproductive aging. 1 in 6 couples will experience infertility. It's such a huge problem, but it's also become a huge industry worth about $40 billion US. And as anyone knows that's been through it, women trying to conceive are so vulnerable to being exploited by misinformation, and there is so much of it around. I also think that for many women, our school sex education taught us a lot about how not to get pregnant, but absolutely nothing on how to get pregnant. And it can often come as a real shock when you don't fall pregnant, having tried most of your adult life to avoid doing so. So I really wanted to do this episode to try and cut through some of this noise, give women and couples an evidence-based take on it all, and try and bust some of those myths. So let's get started. Thank you so much for joining me, Professor Huang. It's lovely to see you.
And I'm very happy to be here, Natalie.
Good. So as I said, I really wanted to get through some misinformation in the fertility space, because I do think it's really ripe for misinformation. I think women are really vulnerable at this time trying to conceive.
Yes.
So I think it's a really important conversation to have. I wondered if we could start with talking about female fertility.
Right.
And just understanding that a little bit in the natural decline in fertility, because obviously we know that as a woman, you're born with all the eggs you're going to have.
Yes.
And at birth, you have about 1 to 2 million. And then at puberty, that has drastically declined to about 400,000. So what happens after that? Take us through what happens to a woman's eggs during her reproductive life after that. And why is there such a drastic decline in the number of eggs?
Right. So Natalie, you are right on point for all the information that you've just given. And it's something that many women don't know. That is once they achieve puberty, they have their first period ever called the menarche. Very nice word to mention, the first period ever. The number of eggs will just start to decline. And that's just how the ovaries are programmed to do at this moment in time, such that unfortunately, at the end of it all, after they've finished all and almost ovulated about 400 eggs in their lifetime, they'll reach the menopause. In Asia, women around Singapore, we found the average age of menopause about 49. And then for Caucasian women and other populations, about 50, 51.
Right.
But during this period of time, the number of eggs, the way it declines, is not linear.
Right.
Which means it doesn't go just, every...
Like in a straight line down.
Yes, it doesn't go like that. Unfortunately, the highest or peak of fertility for any young woman is between 18 years of age to about 30 years old.
Right.
And thereafter that, 32 onwards, the decline starts to be more steep. And once you hit 35, it goes another drop.
Right.
Which most women by that time will realize that 35 is the magic number or the bad number to have.
Yeah.
And then at 37, there'll be this drastic steep decline in the number of eggs dropping, as well as the quality of eggs being not ideal and getting poor in quality. Once about 40, it gets really low in numbers. And the qualities also start to depreciate much more. And then thereafter that, it will just go down. Right. So the chance of you conceiving naturally at age 40 is about 10%.
Right.
So it's not zero for women. That's why you still hear some news that women at 40 still can get pregnant, but it's only 10%. And that is the real proportion of women at that age that gets pregnant. And once you hit about 45 years of age, because people now assume that anyone can get pregnant with the technology out there, but really it's really less than 1 to 2%.
That's so interesting, because I think one of the things is that women will see celebrities getting pregnant well into their 40s, sometimes even 50s. They will hear stories about egg freezing being an insurance policy, or they'll feel like, oh, well, I've always got IVF to fall back on. And it's this idea that actually we don't have to worry about the decline in our natural fertility anymore. But you're saying that that's not the case.
Yes, absolutely. So that is the real truth, that sometimes I feel like, I'm the bad person who's saying this all the time to the poor women in front of me, who's now asking me, what do you think? How do you feel? I was like, I'm sorry, I'm looking at the numbers, it's not something very promising. Right. Because you're now of this age and the numbers reach this. So something that I think we need, what you're doing is excellent, the awareness out there to let the women know that, unfortunately the biology is still being studied, but, because once you know this, then you can now start to replan and rethink about your own family planning.
Yes. And do we know why the egg rate decreases at such an alarming rate. Like it's to be born with 1 to 2 million eggs, and then at puberty when you haven't started menstruating at all, and at that stage to be left with only 400,000, it seems like such an enormous decline.
Yeah.
Why does that happen? And does it happen at a different rate in different women?
Well, those are beautiful questions. And those are actually questions that many, many scientists are still looking into. So we don't understand why the ovaries are programmed in such a way, especially in women, that it falls at certain rates at certain age, and then it declines steeply at another time. But, in evolution biology, people talk about, what the social network of human beings are. Perhaps at a certain point in life, women should not be reproducing, but helping her daughters reproduce. So
the grandmother theory. Yeah.
I'm quite sure you heard about that.
Yeah.
And maybe that's why her ovaries have to stop working, because she can't get pregnant herself, because she has to protect her daughters or even granddaughters to have the next generation. And obviously, if anyone looked at a pregnant woman now, how is she going to be catching her fish, milking her cow? And it's really, really tough.
Absolutely.
And not to imagine those prehistoric times where it's hunter-gatherers moments. How is she ever going to run and chase after the prey? It is really just physically not possible.
Makes sense.
So I think the science is still out there. We're still trying to delve into why the ovaries are behaving in such a way. And what you just asked, the next part is really interesting, because we do see that women of different ethnicities, perhaps slightly genetic predispositions, that shows that the rate at which their ovarian reserves, that means the number of eggs they have in their whole total lifetime, how it declines at various parts of ages actually differs.
Right.
So interestingly, it has been shown that actually in the younger Asian women, for example, her ovarian reserve seems to be much higher.
Right.
But recent publications have shown that once she's about 25, in the mid-20s, that decline starts to become more steeper as compared to women of Caucasian ethnicity.
Right.
So that again, we're just wondering, why is that so? But nobody exactly knows those reasons, and we are still trying to find the answer, because if we can find out what causes these eggs in the ovaries to just disappear or not working, then perhaps we have now a way to really help a woman maintain her fertility and keep her eggs, not just numbers but also quality, much better.
And you mentioned genetic factors and ethnicity. Obviously, those are non-modifiable. There's nothing we can do about those. But is there anything that we can change, either in our lifestyle, diet, anything like that, that would change the rate at which our egg supply declines? You're
right. And I would say that other than genetics, as you mentioned, that we can't change completely, lifestyle especially takes a huge part of anyone's life. You're also a clinician, as I am, and we see many, many people, and we tell them, have a healthy lifestyle, eat clean, exercise. These are all good advice, but who should we start that advice, and when and how early? And actually, what I would like to share is that from a time a girl is born, nutrition is utmost importance, because there's so much evidence now that shows that as obesity rates goes up, you see the age of the first period, the menarche as we call it, also starts to get earlier for girls. And this actually is a sign that the body is having excessive amount of fats being deposited much earlier in a girl's life, and that body sort of assume that she's ready now to grow up and perhaps even ready to have a baby. And now what is not so good about that is that if she starts to have her menarche too early, it also suggests that, her metabolic risk factors, all this will start to get higher. And she's now, and we just published in our group that we noticed that women who actually have very young age of menarche, before 12 years of age, actually have higher risk of developing type 2 diabetes later on in life. So I think we all have to start from her childhood.
And is it just the childhood, or does it start even earlier? So does it start even when her mother is pregnant with her? Is that important?
Oh, brilliant, Natalie. There's a nice link upwards. And which is what I always talk about, preconception even. Okay, just even before a woman gets pregnant, that's where she should actually start to look up, look after her health, and look out for good diets to be on, healthy lifestyle. But you see, nobody thinks about that until they decided, okay, I'm going to take that step.
Yes.
And only then they start looking into all these things, which I think is a little bit too late.
I agree.
Yeah.
It's so interesting you mentioned that about the work your group has just published, because I was reading a study the other day that looked at dietary patterns. So it was the Alternative Healthy Eating Index in girls, and the fact that if girls eat that, they are less likely to reach menarche earlier. And it was actually independent of BMI. And so actually the composition of the diet really makes a difference. And obviously the earlier that you can start that, the better. So I think we're all singing from the same hymn sheet there as well. That's great. Okay, so we've talked about the fact that fertility naturally declines, that it declines in different women at different rates, and that actually a lot of that will be genetic in origin, but there are perhaps some modifiable things that you can do with regard to lifestyle, diet and exercise to try and modify that risk a little bit.
Yes, definitely.
Now, egg quantity isn't the whole picture, is it? You've touched on quality.
Yes.
Tell us about the other factors that impact on a woman's fertility or a couple's fertility.
Right. So we talk about obesity. That addresses both men and women.
Yeah.
Because they're at risk of metabolic disorders, for example, diabetes, insulin resistant, hypertension. All these are not great, especially for the woman when she gets pregnant. And again, not so good when it comes to making the important cells that make the new life, which is the sperm and the eggs. And quality is very important, as we all know, because at the end of the day, only a good quality sperm can fertilize a good quality egg.
Yeah.
And many a times I always told couples to stop smoking if they ever are smoking.
Yeah.
We know there are tons of evidence out there that smoking is detrimental to all aspects of health.
Yeah.
And what they do not know, especially some men, is that they do not know that smoking also affects the quality of the sperm. Right. So many men told me that, well, my sperm count is still okay, the numbers are good. But, ongoing studies that we have and others have shown that actually the sperm quality, the DNA quality of that sperm, which is going to pass on that genetic material to the future generations, are actually poor.
Right.
So they will lead to damage in those DNA in the sperm, and this is not going to help, in getting pregnant.
Right.
And of course, problems in the offspring that comes from that fertilization.
Absolutely. So it's not just a female problem, men definitely matter as well.
So obviously when men get so bad, of course, if a woman is passively smoking, which means that her husband is smoking and she's just by the side and taking that smoke, obviously her ovaries are not going to do much better. Yeah.
Okay.
That egg quality will be poor as well.
Okay. So we've got obesity, we've got smoking, alcohol. How does that affect things?
Right, alcohol, something that I like. How about you?
Of course. Everyone likes a glass of wine.
Yeah, I think a glass of wine is fine.
I think a glass of wine is fine. Okay.
Never excessive.
Okay.
Yeah, and of course, if she's trying to get pregnant, for the woman especially, I think she should just really minimize, her alcohol taking. I mean, red wine and all this is still okay, but once she conceives, then we will advise her to stop all alcohol.
Okay.
Yeah.
Okay.
So I think the evidence on alcohol side is not as strong yet, but we know that, of course, the more you take and the type of the alcohol they're taking a lot of beers, which are also high in calories. If you're taking too much of it, that's not so ideal.
Okay.
Yeah.
And on social media, there are just tons of fertility diets, get pregnant diets, all these kind of programs being sold to women. Do you feel that we do have enough evidence to prescribe a fertility diet? We've obviously talked about the importance of nutrition, not just for the mother, but also for the unborn child. So that is clear. But is there any actual evidence that eating in a certain way will help increase your chances of conceiving?
That is a very, very tough question because we are what we eat, isn't it? Right? The right food groups, given the right nutritional needs that we are lacking, will definitely, ensure that our health is in great form and we're in great shape as well. So those fertility diets actually tend to have certain nuance to them. Yeah. About talking about antioxidants, the Mediterranean diet, unprocessed foods, high in proteins.
Which no one can disagree with.
Yeah, I mean, these are all there. It's just how you mix and match all of them into something that is palatable. I use the word palatable because some of this is not palatable.
Yeah.
unfortunately, because I tried losing weight myself. And I think salads without any sauces just doesn't make sense. No. And if an Asian tongue like me, you know.
Yes, it's not going to last long.
No. So we need consistency as well.
Yeah.
You don't just do it because I want to get pregnant.
Yeah.
You do it because I want to be healthy. I want to be good.
Yeah.
I want to enjoy it.
Yeah.
So to me, I think those diets are helpful in general principles.
Yes.
They are great.
Yes.
But it must be something that the woman, the husband, the couple actually enjoys having it.
Yes.
You know, it must be sustainable as well.
Absolutely.
You can't just be thinking, I'll eat for 3 months, I get pregnant, then that's it. So, no, you got to continue.
Exactly.
Right.
Sustainable change.
Yeah. So I think that is important to emphasize. And again, you know, people have different allergies, you know, and different conditions, right? That doesn't allow them to take certain food groups, for example. No seafood allergies, no gluten, and things like that. And I think that is where a professional nutritionist, or what we call dietitian in Singapore, is very helpful. Because if you're not able to take certain types of food, you might be lacking in certain nutrients, minerals, and what sort. And that's where the information is helpful, because you need to replace that.
Absolutely.
And of course, you know, we know that actually a lot of diets are lacking in certain micronutrients. Taking folic acid, for example. Actually, most of our food and diet are lacking that. And because it's water soluble, means that it can just be washed out the body as long as the kidneys are healthy.
Okay.
So there you go.
Yeah. Okay. So diets are definitely important, perhaps not enough evidence to say, to be prescriptive over something and say this is exactly what you need to be eating. It may differ from person to person, but certainly a healthy diet with whole grains, legumes, lack of processed foods, it is important for someone's general health. Yes. Okay. Now, you touched on folic acid, and I was going to talk to you about this because on social media, actually quite recently, there's been a whole furore about folic acid and its effects on postnatal depression and whether or not you need folic acid versus methylfolate. So I'm going to get you to watch a video for me.
Oh, wow. Okay.
Okay. And I want you to tell me what you think of this video.
Oh, right.
I think it was 1993, the U.S. federal government agreed to spray our entire grain supply with folic acid. All white flour, white rice, white bread, white pasta, grains of all kinds are fortified or enriched, which means they're sprayed with the chemical folic acid. It was initially because they thought it would prevent a neural tube defect in pregnant women, but the truth is folic acid doesn't prevent anything. The body has to convert it into methylfolate to prevent a neural tube defect. In fact, pregnant women that take high doses of folic acid and have this gene mutation have very high incidences of postpartum depression. Because what happens to a female that cannot process folic acid when you put 1,400% of the daily allowance of folic acid into her body? She goes nuts. And she develops this depressive state. And then eventually the pregnancy ends. They stop taking the prenatal vitamin. The symptoms go away. So they blame it on the pregnancy, not on the vitamin.
So that's a chiropractor who is, I think that video has got about 17,000 likes on Instagram alone, probably more on some other platforms. But I think it's really important just to discuss this because I think we know what the evidence is for folic acid in neural tube defects. I think there are two things he said there which I'd like to discuss. So the first one was that he kind of insinuated that he said, initially they thought that folic acid helped prevent neural tube defects. Well, we know that it does, correct?
Yeah.
That's not something we initially thought and now don't think. That is something that we know.
No, I think that is the only one that was the only supplement that ever we advised because it has been through many trials, randomized control trials, as you know, systematic reviews and meta-analysis have shown that was the only nutrient, micronutrient perhaps, that we should supplement for all women because it was clearly associated with neural tube defects.
Absolutely. And I think that is just uncontroversial, actually. Neural tube defects are definitely prevented by prenatal folic acid, and that's not in question at all. So that's completely false. And the second thing he was saying was that there's evidence that folic acid supplementation in the pregnancy can cause increased rates of postpartum depression. I haven't found any evidence of that. Have you?
Actually, I have heard nothing of that yet.
There you go.
And really, I think anything can cause a woman to go into postpartum depression. And I think what was clearly associated is a woman's pre-pregnancy moods
Yeah,
and mental state actually
exactly.
are actually the risk factors for her having postpartum depression.
Absolutely.
And any postpartum disorders.
Yeah.
Actually.
I mean, I think postnatal depression is caused by many things, like you say, a pre-existing mental health condition, hormonal shifts, sleep deprivation, lack
Absolutely.
of support, financial strain, social determinants of health, so many things. But I do not think that we can say that folic acid is one of those causes. I don't think there's any evidence to say that at all.
No.
One of the things that he's pointing to is the idea that we're giving folic acid to women who've got the MTHFR mutation, and that's the wrong thing to do. And I think there are lots of women out there who have tested, I think you can test for it quite freely now, who've tested and know that they have it or worried that they might have it and are now thinking, oh, should I be taking folic acid? Should I be taking something else? What's your advice to women who know that they've got this mutation?
I think importantly is you have to understand what this mutation means.
Great.
Right? And get it from reliable sources and people who manages people with this condition. And truly, unfortunately, there's so many genetic mutations in many of us. Actually, many of this doesn't cause problems to us. It may cause problems when we try to get pregnant, for example. It may cause problems if you have your partner who is having that mutation and can perhaps pass on another genetic condition. But those again are a different discussion. And I think that they shouldn't jump and start get frantic all of a sudden. I think understanding that is important. And I think the lack of understanding or assuming that they know about it is insufficient for them to just say that this is wrong or by doing this, I will get that.
Exactly.
And I think even getting high doses of folic acid, which at least in this place we are practicing in Singapore, 5 milligrams is considered a high dose. The prenatal supplement is about 400 micrograms. I mean, how much is that? Yeah. And assuming all our kidneys are healthy and we're in the best state of health.
But I think all the evidence or the guidelines suggest that even if you do have an MTHFR mutation, the advice is to take folic acid and then it will still work. And that is the supplement that's got the most evidence, as you said.
Yes.
Right?
Absolutely.
Yeah. Okay. Do you, because I think supplements is such a big thing. I think you probably see it in your practice all the time, people coming in and going, well, what supplements should I take? What supplements should I take? Yes. Apart from folic acid, do you routinely advise any others?
I have a favorite one, but that's also because it's evidence-based.
Okay.
Like, I just feel that I have to be responsible for the women I look after.
Absolutely.
Yeah. And I think one important thing that women don't know as well is their bone health. That all their bone mass is all accumulated when they are growing up.
Yes.
And that's when they are a child, when they go through adolescence and puberty, and calcium and vitamin D is very important. Absolutely. Again, those have so much evidence on them that you can't deny that this is not something that women need more than, well, I'm not saying more than men, but more than the regular individual, right? Yeah. Especially during various parts of their, reproductive lifespan. For example, breastfeeding, pregnancy, you definitely need more calcium and vitamin D. Yeah. And of course, if you're going to get there, you might as well just make sure that preconceptually, before you get pregnant, you make sure that you have all good levels of vitamin D and calcium. Yes. I'm sorry to say that, but all women don't want to have the sun, especially in this part of the world. In Singapore, all the Asian women are just like
hiding from the sun.
Yes.
Yes. Yes.
And unfortunately, I love the sun, but I kept working until the sun goes down. Yes. And I'm actually low vitamin D as well.
As many people are, even in Singapore where it's absolutely...
Precisely. Yeah. And there we go. So we all need some calcium and vitamin D. That's something that I actually would advise that because vitamin D really has a lot of good benefits or for prevention of our bone health, all the way to ensuring healthy pregnancy, fertility, as well as there's been some studies that show that it might even help reduce the risk of getting hypertension during pregnancy for those who are at risk. So, I mean, again, those are just some studies, but I think in general, this supplement is still important for women who are going through these different physiological states in life, which requires more of calcium and vitamin D to ensure that the next generation, the fetus is growing and have enough calcium and vitamin D. Her own constitution is being strengthened so that she can be prepared for the pregnancy as well as for breastfeeding later on.
Great. Okay. So when you are in clinic and you are seeing a couple who perhaps they haven't yet started to conceive, but maybe they're coming to you for preconception counselling.
Right.
What are you telling them about how to approach this period? So you've obviously would have spoken about supplements. What are you telling them about frequency of intercourse or timing of intercourse or using?
Oh, gosh.
What is your advice
You're
there?
triggering me.
Go on, tell me.
You know what? When they come to my clinic,
Yeah.
I just feel so drained at times because of telling them, how often do you have sex?
Yes.
You have to be open about this. That's
Yes.
how natural conception happens.
Of course.
We've
Got to be comfortable about talking about sex.
Yes,
If we're talking about
sex is
trying to
beautiful,
conceive.
sex is healthy.
Yes.
In the right context, it is almost sacred, to me,
Yes,
because
yes.
it's when new life is formed
Yeah.
from the act of love,
Yeah.
And no, they start telling me, oh, I use this thing to time, I use that to estimate my ovulation.
Yes.
And then I asked my husband to come, I was like, oh my God,
Yeah.
this is so mechanical.
It is. Yeah. And it can sometimes cause more problems, can't it?
Oh my God, they have, they have more problems than ever.
Yeah.
Yeah, because eventually a man is like, I'm too stressed, I can't do this.
Absolutely.
Yeah.
Yeah.
And the woman's like, I'm so stressed, I
Yes.
don't like this.
Yes.
So why stress yourself, right? There must be a reason why women are not behaving like other female species when they ovulate, right? That's because human beings are born, they form a very close, intimate bond, and they need to have regular intercourse.
Yes.
Not just at the moment of ovulation.
Exactly. I tell my patients that all the time.
Yeah,
but
but they
my
don't believe in
goodness,
you.
I know, but my goodness.
Because all they just say, I'm very tired after work and I don't like to do this. And I'm like,
Yeah.
and they got me open up my eyes really big and staring at them. It's like, you're both married.
Yeah.
And you love each other and that's why you're here. You want to have a child together.
Yeah. Yeah.
And why are you finding having sex tiring?
Yes, and it's usually because they're trying to go for these 1 or 2 days and have a lot of sex in those 1 or 2. And of course, if you try and do that, then it is going to be a little bit more of an effort. So yes, having regular sex throughout the month is what we advise, isn't it?
And an important thing, I go back to biology, you see, because a man's sperm can live in a woman's body for 2 to 3 days, and which is why we are just asking you to have regular intercourse after the women have finished her periods. You can just start from that day.
Yeah.
Every 2-3 days.
Yeah.
Because when the elusive egg comes out or ovulates, there are really no true physical signs that will 100% tells us that she is ovulating.
Yeah.
These are all what we call surrogates of the real event.
Yes.
A woman also doesn't becomes more receptive to a male during that time of ovulation. And even though, yes, her discharge may change and all this, but it is very subtle.
Yeah.
I always tell the men, you must fill the entire reproductive system with lots of sperm.
There we go.
Such that once...
That's your job.
Yes, there's once the egg comes out, she's only that attractive for that less than 24 hours, but she can be fertilized.
Right.
Right? And you're right there waiting for her.
Yes.
And there you go.
But because the sperm can last 2 or 3 days, if you have intercourse 3 days before the ovulation,
well, you have a higher chance.
You can still conceive.
Well, so the interesting fact is that actually pregnancy rates are highest when they have sex before the day of ovulation.
There we go. And therefore, waiting until you get that kind of ovulation stick, mark that says you've ovulated might be too late.
It's already too late.
There we go. Okay, there we go.
Yes.
So I'm going to ask you a follow-on question for that, but I think I know what your answer is. When couples come in, because there are lots of companies selling ovulation sticks, what's your advice to them about that? Do you use them? Do you not? If a woman's having a regular monthly cycle, does she need to use ovulation kits as well?
The truth. I wish I was selling those sticks.
If it was ethical,
yes.
If only it were ethical. But
Yes.
you're going to tell me it doesn't sound like it is.
No. I really wouldn't want them to be so stressed about that.
Yeah.
And depending on where they buy the sticks, reliability changes.
Yeah.
And also that stress level goes up. Because what if that stick doesn't turn positive?
Yeah.
And many couples would just tell me, oh, because my waste of time is not positive. I'm not going to do anything if it's not... a child is made out of love. It's made out of a partnership, an intimate, loving partnership. And so that stick is not creating that. It's just only making stress and making them more stressed it might even cause strains in a relationship, because sex now is not being intimate, being loving, but it's a chore.
It's a job. Yeah.
You know, it's an act to an outcome, and when you linked everything like a job, you won't be too happy doing that.
Yeah, absolutely. Okay, so when you are seeing that couple, a lot of patients will now say, okay, I'm here for preconception counselling, but I just want you to do all the tests because I just want to know.
Yes.
I want to know now before I start trying if there's going to be a problem. What's your advice to women or couples about that? Is there any evidence to say, actually, even before you start trying to conceive, that it's worth knowing what your semen parameters are, knowing what your AMH, and we'll talk about that in a minute, is doing all the testing before you even start trying to conceive in a couple that are healthy and otherwise well?
Now that is a very tough question, Natalie, because I have my own version of it, being someone who's doing fertility, because a lot of time what we are looking, and a lot of even very healthy young men and women, you know, who are similarly healthy, they may still have reproductive issues. And unfortunately, we just don't know enough right at that point in time. So I think if they are really planning to have a family, knowing early does help.
Okay.
Because at the same time, if they could correct some of their lifestyle behavior, for example, smoking, you know, maybe over drinking, for example, you know, or like the woman like is a marathon runner and running like 20 kilometers every 2 days. I think that again is not too healthy. Right? You know, she's in the body will take as stressed. Right. So if she knows where her reproductive health is at that point in time, and sort of tailor her lifestyle and also aspirations of becoming a mother or their aspirations of becoming parents, then I think it's worth to at least, you know, assess that. Because what I'm going to share next, you might be agreeing or may have more questions for me, because now as I look at reproductive health as a whole, I think it is also a sign of general health.
Absolutely.
Because there have been so many population and cohort studies that have shown, especially in men who have healthy semen parameters all the way up to when they are much older men in midlife, it shows that their longevity actually increases.
Right.
Their health span is improved.
Right.
And they're at lower risk of cardiovascular risk factors.
Right.
So which means that what is happening in the gonads is equally important, and
it's a reflection of the entire body.
The general health as well. Because unfortunately, if you are genetically predisposed to some reproductive conditions, I'm not sure about this Klinefelter syndrome in men. Klinefelter syndrome unfortunately affects men. It's not as uncommon, but it's about 1 in a few thousand. And well, normal men have what we call X and Y chromosome, 46 in total, the number of chromosomes that make up a whole human being. Now, this man have extra X chromosome, so they become 47 XXY. Now, what happens is that this man, unfortunately, their sperm count drops very early on, and they start losing their testicular function, which means that their male testosterone levels also drop very early on in life. So by the time they are in early 30s, they might have no sperm. And when they reach about late 30s, they will be suffering from what men were talking about, you know, the low testosterone problem, which is hypogonadism. And this man needs to have testosterone replaced for that general health and well-being. Because again, men and women can't do without, you know, there'll be a different conversation, but you know, they still need their sex hormones to maintain that level of health, muscle mass, and whatsoever.
So a true andropause is what you're talking about.
Well, that's what we're saying. Although I didn't want to coin that
You
word. So I mean, for men, it's as clear as that. And how about in women? Because in women, there have been even studies that shown that unfortunately, if your ovarian reserve, that means the egg count, is really low when you're younger women, it does seems to predict that you seem to go into menopause much early on in life, and which means that your healthy lifespan and longevity is going to be affected. So to me, you know, it's a good thing that if they are thinking of having a family, to actually screen that early, to actually find out, do they have a problem or not? And of course, if they are healthy and well, everything seems good, then I give them their blessings. Carry on. You know, time is still there. But if not, then I think they need to seek early treatment such that, you know, what we have all this, you know, even though uncommon conditions, we can actually tackle them early. And then we talk about healthy longevity as well for these couples.
And it's a great time to test and intervene, because often people are very motivated at that point in their life, aren't they?
Yes.
You know, if you say, actually, you know, your semen parameters don't look great and you need to change your lifestyle on X, Y, and Z. Often if you're saying that because of a kind of abstract concept of high blood pressure or cardiovascular disease, they might not take to it so well as if you're saying, well, actually, if you want to try and conceive, this is the way to get that child that you so want. So actually, it's a good way to intervene. Okay, so yes, for testing preemptively. What does that testing look like? So what types of things are you going to be doing?
Well, I think as doctors, what we really want is that we should have a detailed as possible, and an honest, you know, history taking with the couple. Yeah. You know, really, men and women, we need to get everything that we need to know about them. Yeah. From young till now. That medical history, their exposure, you know, sexually transmitted infections, smoking, drinking, drugs, you know. I think all these are important because this is what they've been exposed to. And sometimes, you know, some of them who, as children, may have cancer, something like that. And they may get treatment and then they forget all about it because they are well and jumping around. And you know, that sort of horror of their treatment was just at the back of the mind. Yeah. But these are all frank discussions that we need to have. Yes. And then come surface it and then we assess them accordingly. But really, if a young man has no major issues, I will also check their sexual function. Yeah. And that's very simple. It's just asking if their morning erections are good, if sex is all right, erection, ejaculation all in place. Yeah. Everything's good, then, well, all we need is just semen analysis. Okay. As simple as that for
a guy.
Yeah.
Okay.
Well, women needs a lot more tests though.
Tell us about that.
Well, so same thing. We understand the women through all entire lifestyle, medical history, but we also need to know about her menstrual cycles, and that's something I love to talk about. It can go on forever. Yes. Go on. Because what a lot of work that we're doing now, and what is in the literature, as you know, is that regular menstrual cycles that say a lot about a woman's, you know, general health and well-being. Yeah,
it really is another vital sign.
Yeah. Yeah. Oh, I love that term. And yes, I totally agree that the menstrual cycle for me is the sixth vital sign other than the heart rate, blood pressure, and everything else, because this is what actually alerts her to so many things that's happening to her. And I think that a woman needs to know her menstrual cycle and patterns very well. Yes. It starts as soon as we asking at what is your age of menarche, right? Which is, we talked about earlier on. Yeah. And then I'll say, how are your periods all this while? Has it been regular? Is it doing the stipulated, you know, clinicians and doctors have this number of days that they like.
We like the 28. We like them.
That perfect number of days. But, well, everyone's a little bit different.
They are.
But if they fall within that normal range, we'll be happy, right?
Tell everyone what the normal range is. So what are you happy with?
Well, the textbooks and literature says between 21 days to 35 days. Now, most women fall between, I would say, between 25 to about 30 days. They are rough average, but you know, once they're around that range, I'll be happy. Yeah. And I will also know about their menstrual flow as well. Because if their periods are really heavy, lots of clots, you know, this doesn't sound correct. Yeah. Because she's highly likely to be anemic. Yes. And she's anemic, well, then she need to take another supplement, which I love to give, which is a iron supplement, because you know, it'll make her life change a lot.
Yes, absolutely.
And her general well-being. Can you imagine she being anemic? She's giddy spells, lightheadedness, and all this, concentration, memory,
fatigue.
You know, no way. These are all bad things. And so it's just a menstrual cycle alone can get so much information. Yes. And again, is there associated pain? Because we're thinking about other gynecological conditions, for example, endometriosis, perhaps pelvic inflammatory disease. You know, and these are things that can affect her fertility. Yeah. And we need to deal with it early rather than later.
So if a woman comes in and she says to you, Professor Huang, I have a 28-day cycle, always been 28 days. My bleeding, I bleed for about 3 days. It's not particularly heavy, not particularly painful. What's your takeaway from that?
Well, my takeaway is that this woman sounds like she is in general good health. And I think she should be reassured that she's keeping herself well as much as possible. But there's another caveat that I still want to look, which is if you're planning for pregnancies, I also want to check what your egg reserves are like, and your reproductive hormones behave.
Yes.
And it all depends on which part of her life she's at.
Yeah.
So if she's a 25-year woman, I'll be less pushy,
Yeah.
to do a lot of tests on her,
Mm-hmm.
but to emphasize healthy lifestyle, healthy eating, keeping her menstrual cycles regular as she is, and to offer fertility screening if she feels that she really needs to know, right? And I think that's a comment that I must have with her.
Yes.
But if someone comes in at that age and telling me that she has irregular cycles, things are not right, I'll be very hesitant to just stop there.
Absolutely.
I'll offer more than just the normal reproductive hormones, the egg resistive tests that we're doing. I'll be offering maybe an endocrine kind of a review, like a thyroid function,
Yes.
looking at her blood count, just to be very sure that she doesn't have other underlying causes. So I think in that young woman that you portray, if she is 39 years old, I would still offer fertility screening as soon as possible.
Okay.
Because that age and quality still makes a lot of difference,
Okay.
to ultimately what her outcomes are if she decides to have a family.
Okay. And now I think the test or the fertility screening test that most women will have heard of, particularly if they are trying to conceive, is something called the AMH, the anti-Müllerian hormone.
Yes.
Tell us about that. Tell us what it can tell us about and tell us what it can't tell us about.
Again, you always ask the right questions. That's fantastic, because this is something that I would like to say. It is a good currently used clinical marker, but it's not perfect. So I'll just start, why is it good?
Yeah.
So a lot of studies and the experts who first found this molecule, the anti-Müllerian hormone, is a very interesting molecule because in women, it's only produced in the ovaries.
Yeah.
From the granular cells, which is my favorite pet topic. I will just now make it very simple. These are cells that actually supports your egg's growth throughout its entire development in life.
Yeah.
And so it's very unique and special, and it's only found in your ovary.
Got it.
And it doesn't vary with the menstrual cycle, so it's quite consistent because it's being produced from very small, what we call antral follicles. And this is our follicles that has been selected to come out every month to be ovulated, but they are not yet growing fast enough. So they are a good number for us to sort of predict, what her likely response to IVF is like, how likely, she's going into menopause. If she has a good number at a certain age, it might predict that, okay, she will probably behave like a normal woman and how she, the age at which she reaches menopause.
Got it.
But there are problems with AMH as well.
Tell us.
If a woman smokes excessively, if she's pregnant, if she's on any hormonal kind of pills or medications,
Yes.
this is suppressed.
Right.
Or if she have a cyst removed from the ovary and the test is done too soon, again, the numbers are not accurate.
Right.
Or if she has a tumor of the granular cells,
Got it.
it'll be excessively high. So you see, there's some conditions and some normal conditions that actually precludes us from using AMH exclusively.
Yes.
And so I think that's a caveat that people have to understand. When you interpret that result, it has to be interpreted in the right setting.
In the context, yeah.
And precisely contextualizing it and making sure that which part of the cycle did she measure at? Is she on any other medications or hormones? And what is the physiological state that she's at the moment in time?
Yeah, because I see a lot of women who come in clutching their AMH result and will be incredibly upset when they get a lower result.
Of course.
But that's not saying you will never get pregnant, you have absolutely no eggs. It's not saying that at all. There is still a chance that you can get pregnant. It's just that based on this test, it's showing that you might have a lower level of ovarian reserve. Is that correct?
Absolutely correct. So that just gives you an estimate of how likely are the number of eggs that you have still left in your ovaries at that point in time where we test it. So it changes, like I mentioned earlier on. The values can change, and it changes faster when we are getting older. And that decline, unfortunately, we're still trying to understand why is that so. But that number is really just for quantity. Many researchers and clinicians are trying to link it to quality, but the data is definitely not there yet.
Okay.
So I would say for AMH, it is really a number for quantity.
Right.
In the right context, and given all the caveats I've given before, and interpreted in that light, it is relatively reliable.
Okay.
Again, we need to be age specific, and now the new term, but ethnic specific as well.
Okay.
Yeah, because how it goes, as you mentioned, if you see different rates that things goes down in different populations, that might be saying something. And I think we need to sort of have those numbers, but yet we do not have all those in place at this moment in time.
Yeah, but I think that's important. I mean, I think giving personalised care and personalised risk assessment is really, really important for women. Okay, so you said that it tells us mainly about egg quantity. Is there anything that can tell us about egg quality?
We are still searching for that.
We're searching for it. Okay.
And thus far, doctors just use the word age for everything.
Okay.
And I would say that it is true in majority of cases, but there are some instances whereby, a woman at 40, so as I mentioned, 10% of them still have healthy, good quality eggs that give you healthy, normal pregnancies.
Okay.
And we have to understand that, that's how amazing biology is, because it still allows human race to carry on even what we thought that they are older.
Yeah.
Yeah. And you're right. It may not be a number games, because I have mummies who actually got themselves pregnant on their own with very, low AMH levels.
Yeah. And I've seen that as well. So it's not just a numbers game. Okay. Now, we talked before when we were talking about the menstrual cycle being the sixth vital sign about the idea that if you don't have a regular menstrual cycle, that can be kind of like a mirror to underlying problems.
Yes.
And one of those problems, I suppose, could be polycystic ovarian syndrome, which is a common cause of subfertility in women. Yes. Tell us about that. How would that present?
Well, there's another pet topic that I love to talk about.
Oh, great. I'm getting all your pet topics. This is great. I've read your mind.
Yes. And I was like, oh gosh, everything I need to talk about at this. Polycystic ovarian syndrome, to me, it's very unique because it is still a syndrome, and there is still no known etiology that everybody agrees on, right? Endocrinologist is saying one thing, reproductive endocrinologist is saying another thing, fertility specialist is only looking at one part of it as well. And I think that the current criteria that we're using clinically, and I'm just mentioning one of the many, which is the Rotterdam 2003 criteria that we're using. Experts in looking at PCOS have all now come to the latest PCOS guidelines, and I mentioned that actually PCOS, is both a metabolic condition as well as a reproductive condition, and we are now of the mind that we might even have to tease this out carefully because we are labeling women too early as well.
Right.
And so what I would say for PCOS is that don't overdiagnose it too early.
Okay.
And I think the recent guidelines have mentioned that for young women, especially those who just got their periods in the first 4 to 5 years of their life, they are not likely to be ovulating.
Yes.
They might have longer, shorter cycles. And mind you, the young girl in the puberty, she has so much to go through. The body changes, the mood swings, the things to adapt, everything. And so, her cycles may not be as regular as one think it is. But after 8 years post-menarche, if that pattern persists, then it's something that we need to look further into. And I think one of the things that we talk about is the Rotterdam criteria, as well as the Androgen Access Society was mentioning about that. They felt that this condition, especially in women, will warrant a measurement of her blood testosterone to be higher than the normal level expected of a woman.
Right.
And that is important, and that needs to exclude other endocrine problems that doesn't cause high testosterone levels to sort of qualify as one of the criteria.
Yep.
And the next one, of course, is regular cycles, which is very easy for clinicians and the women herself to volunteer to us.
Yep.
And finally, is really to do, I had to use the technical term of transvaginal ultrasound scan to really assess the ovaries of these women to make sure that they have what we term the polycystic ovarian morphology, right? To really make the diagnosis of PCOS. But does everyone fulfill this criteria? No.
Yeah.
And we know in certain populations as well, well, a lot of women are not so hirsute, especially in this part of the world.
Yeah.
You know, and so that part about having high testosterone level and, you know, a woman having male pattern hair loss
Yeah.
or male pattern hair growth on their bodies doesn't really weigh in.
Right.
And a lot of these women were just having irregular cycles. And perhaps if they're suitable, that means they have vaginal intercourse before, that their ovaries are looking polycystic.
Right.
And then we sort of, okay, maybe she's polycystic ovarian syndrome.
And it's really interesting that you talk about post-menarche and how long you should wait after menarche for those periods to regulate. Because I obviously understood that periods can be irregular due to the, you know, immaturation of the brain ovary connection. But I imagine that, you know, by 3 years, actually that should be mature enough and should have. But it's interesting that you say actually we can wait longer.
Yes.
Is that right?
Yes.
And it's common for young girls, so adolescents, to actually have that PCO morphology on their ultrasound, isn't it? So again, another reason why maybe we should be waiting longer to try and...
Isn't it good that a young girl has a lot of follicles in her ovaries?
Yeah.
I mean, why are we labeling that as PCOS so early on and subjecting her to, you know, a lot of tests and anxiety?
Yeah.
You know, and I even heard, you know, perhaps, you know, of misinformation that they were told that they will never get pregnant in their lives.
Yeah.
And that is very distressing for young women at that point in time.
Absolutely.
And you know, that carries on until they're adult women when they come to a fertility clinic, and I did not hear this once but twice. And many a times these doctors are trained in first world countries. So my thought is that we really need, you know, to raise awareness and education about this condition.
Yeah.
And again, one thing that's my pet topic that you haven't asked, maybe you will get there.
Okay.
Is women health research.
Yeah.
Like we really need that investment.
We certainly do.
To really understand it truly, such that, you know, we know what we're doing, you know, and to the best interest for the women in front of us.
Absolutely. So bringing PCOS back to fertility then, and we talked about irregular cycles, but exactly talk to us about the lack of ovulation, and that's how it kind of translates into difficulty getting pregnant, isn't it? So what happens there? Right.
So to me, having PCOS is not really something that's worrying for fertility specialists.
Okay.
Because first of all, most of our PCOS, or almost all PCOS women, have very high AMH levels, usually high ovarian reserves.
Yes.
And some of the highest numbers of oocytes I've ever retrieved from are from ladies with PCOS, 20, 30 eggs, you know.
Right.
For IVF, I'm sorry, I'm not advising them for IVF, but if they
yes.
need to, they have lots of eggs.
Got it.
Not worrying. The secondly is that, you know, a lot of time PCOS is associated with obesity, right? With metabolic disorders. And it's something that if a woman have higher body mass index, you know, well, we could do very simple lifestyle modification for them from the beginning. You know, these are the women that really need a physical activity.
Yeah.
They need a change in their nutrition and dietary habits, so that we could change them such that their body will respond, be less insulin resistant, because it is associated with PCOS, but it's not present in all women as well.
Got it.
It's just more common. And to be honest, actually many women that I see for PCOS are actually slim, definitely not insulin resistant, and having irregular cycles and very high ovarian reserves.
Right.
So, you know, what do I do with these women? I can't ask them to lose some more weight and not eat anymore, because they're
slim already. They're lean. Yeah.
So, but we have very effective medications, which we can help them to ovulate.
Right.
And truly, once they ovulate, actually many of them fall pregnant.
Yeah.
Or if they change a little bit of their lifestyle, reduce the stress a little bit more, you know, they actually got pregnant on their own.
Amazing.
And we started young, and lots of sex, of course.
Of course.
Yes.
And what is it, if you can explain it in layman's terms for us, these are women who have a high ovarian reserve,
Yes.
They're lean, they don't have insulin resistance, but they still are not ovulating. What is going on in that ovary to stop them ovulating? What do we know why?
I think the correct answer to tell is that we still don't know exactly why, but this could be what we say PCOS-like ovaries.
Right.
Right. They could actually behave a bit like PCOS ovaries. They're not ovulating. They're not responding. And actually some of them are from very, very slim women who perhaps are what we call hypogonadism,
Right.
hypogonadotropic, because
Right.
they're just exercising too much.
Got it.
They've too little body fat.
Yeah.
And you just need to get. And this is a group that you start telling them, please eat,
Yes.
please reduce your exercise.
Yes.
I have to change my pitch every time because
Yes.
I can't say this thing to another woman who's completely different profile, and
All
so
individual.
and so some of them actually are that profile,
Yeah.
which I've seen before, and they're so hard to manage.
Yeah.
Because they always say that, no, I can't eat that much. No, I need to run. And you're like, oh gosh, what can I do?
Yes.
What else can I do?
And particularly if they've been told in the past, you've got polycystic ovarian syndrome and you need to watch your sugars, you need to exercise, you need to make sure you're not overweight, then that can be difficult for them to kind of overcome in their minds, having been told that the whole time.
Yes, precisely. And it's so hard to change their mindset.
Yeah.
But of course, when one get pregnant, many women do listen.
Right.
And they do want to,
Absolutely.
be in the best of health so that they could fall pregnant as well.
Just quickly touching on endometriosis, because you mentioned that.
Yes.
How does that affect fertility? Because that's not a condition that necessarily, I think it affects women's fertility in a myriad of ways. So can you tell us about some of the ways in which it does that?
I think endometriosis is a very enigmatic condition because it doesn't mean that you have severe menstrual cramps, you will have endometriosis.
Yeah.
On the contrary, there's some women who got pregnant, delivered their babies, and only on cesarean sections they realize that, oh my God, maybe she has endometriosis. There's so much scarring down, such a difficult C-section, even though she has no surgeries before. And that's why I say it's a condition that unfortunately can be very, very difficult to diagnose at times, but we can't forget about it because it causes too much change in quality of life for these women.
Unbelievable.
And I would say that, having pains, which most women have with endometriosis, is something that will stop them from having intercourse.
Yeah.
So if I'm being intimate with their partners, dislike having periods, and they are scared of having periods, and they will be using lots of hormones trying to stop the periods from coming. And that's by itself is already stopping their natural way of conceiving.
Of course.
Okay.
Yeah.
And not to forget that if the endometriosis affect the ovaries, it's not going to do great for the egg reserve and the egg quality as well.
Right.
There's been enough data that have shown that having an endometrioma, what we call a chocolate ovarian cyst, which is an endometriosis that's in the ovary, it definitely have effect on the quality and the number of eggs that women will have.
Right.
And in our own group of women that we are looking at, we actually saw a difference, especially in women who do not have surgeries for endometriosis, but just that diagnosis alone showed that these women, ovarian reserve numbers are much lower than women who do not have endometriosis. So we still don't know why and how endometriosis. There are a lot of postulations as to why that may occur because due to scarring, due to scarring of the ovarian tissues itself, perhaps the oxidative stress that's from the endometriotic cyst, affect the quality of the oocytes, they die earlier, and all this could actually have an indirect and direct impact on a woman's fertility.
Right. So that brings us on to, I suppose, my next question, which is about egg freezing. So I suppose you've given us a very good example of an indication where a woman might want to have elective egg freezing because she knows that she's got a condition like endometriosis, which can affect women's fertility in a myriad of ways, as you've discussed. So let's talk about that then. Let's talk about egg freezing for medical reasons versus elective egg freezing.
I think the clear indications for medical conditions, there's no doubt. I totally agree with that. And it's the only chance, perhaps, for some women to actually preserve their fertility. Yeah. Especially you need to go through chemotherapy, radiotherapy, that could really harm their egg reserves for the rest of their lives. So in this case, no qualms about it. Yeah. We'll just do what's necessary, try to get those eggs, whatever way. Yeah. Now, there are a few ways of doing it. And of course, if a woman can have IVF, we would ideally, and have some time before a treatment, we ideally do what we call ovarian stimulation. Yes. Which is basically to stimulate ovaries to have as many eggs as possible, and through a daily injections with the medications. And hopefully, once they have enough follicles, we can, when they're ready, we'll just pick as many eggs out as possible. It's almost like IVF. Yes. And of course, if she has a partner, we'll fertilize these eggs that's from the partner. And in Singapore context, they need to be married,
Yes.
right?
And can I ask why you do it? Is it because success rates are better with frozen embryos versus frozen eggs?
You're so smart, Natalie. That's absolutely true, because the embryos technology of freezing a multicellular, embryo is much more robust than freezing oocytes, which is a very large cell containing a lot of water. And that freezing itself could actually result in that oocyte losing its own quality and also its survivability.
So interesting. Okay.
So basically, embryos freeze better, and sperm freeze better than oocytes altogether. So oocytes are one that, despite the technology, is still not 100%. That we will say that, after we freeze your oocytes, we'll get back all the oocytes.
Yes.
We'll never say that. There will be some losses.
And that's really tricky, because I do feel, I see it kind of marketed almost on social media as being like an insurance policy. It's okay, you want to go full speed ahead on your career. Don't worry, you can just freeze your eggs, and then of course you'll have a baby when you're in your 40s. But I don't think women are necessarily being told enough about the idea that it's not 100% guaranteed.
Yes.
What are the success rates? So I imagine it's age dependent when you freeze your eggs.
Yes.
So for example, a 35-year-old woman who's freezing her eggs, what are the chances of that batch of eggs actually making it to a live birth?
Well, I'll give you an overall number first.
Okay, yeah.
With egg freezing, the chance is only 8% of live birth.
Wow.
And can you imagine if she comes in at 38 or 39, that number drops further.
Wow.
So that's an overall number. So that includes young women with lots of good quality eggs. And so I would say that it is not a great number. And of course, to have a live birth, the younger you are, the lesser eggs you will need to freeze.
Right.
So if you come in at 20, below 30, 25 perhaps, you probably just need to freeze 20 eggs. And there'll be good insurance at least for a live birth, giving that low chance.
And do you usually see that number of eggs in one cycle?
Not if you are 35.
Okay.
Yeah, so most 35 years old don't give 20 eggs.
Right, okay.
So, but the number to freeze, if for elective reasons, that's for my own life plans, the older you are, the more we need to freeze.
Right.
But we know the converse is true, because as you get older, the number of eggs ever left in your body is only going to be that few. And the quality also changes.
Right.
So I would say that it is an insurance, but it's not a foolproof insurance.
Yeah.
And the only insurance is that you start as early as possible and as many as you can get. And the truth is, I would say that one cycle is almost never enough, because most women are what we call normal responders to the medications we use to try to get as many egg follicles as we can. And the medications we use are really limited, because we all depend on the number of eggs the woman will produce every month.
Yes.
So again, if you tell me that, you use higher dosages, and I was like, yes, I could use higher dosages, but that doesn't mean I'll get more eggs growing.
Right.
Right. And that's something that they need to understand as well. And in Singapore, elective egg freezing still needs to be paid out of pocket as well. So she does need to know the cost of the procedure itself.
Per cycle, how much is it?
Well, on average, it's at least 10,000 Singapore dollars and above.
Wow. Okay.
Yeah.
It's a big outlay. And then, of course, she's then paying for the storage every year.
Absolutely. So that is another cost she has to be aware about as well.
Yeah. Okay. So it's an insurance of sorts, but it's certainly not a guarantee, is what you're saying.
Yes, it is.
Okay.
Not a guarantee.
Can we talk a little bit about miscarriage? Because that's incredibly common and can be incredibly devastating. And I'd like to talk a little bit about kind of, again, is there anything modifiable that couples can do to try and reduce their risk of miscarriage? What are your thoughts on that?
Well, my thoughts on that is that as much as possible, start young.
Okay.
Miscarriages are common. It's devastating to any couples who are trying to have a family. And we quote, because human reproduction is really a very wasteful process.
Yeah.
About 1 in 5 clinically diagnosed pregnancy actually do end up as a miscarriage. And of course, that numbers gets more common as a woman gets older. All because because it's a lot of times due to quality of the egg itself. And not to mention that, we blame women all the time for the age and the quality of the eggs. But I will also now put men into the limelight.
Okay.
Men with unhealthy sperm, we know, especially those with very poor DNA quality, as I mentioned before, actually also predisposes their partners to having recurrent miscarriages risk as well.
Interesting. Can I show you another video?
Oh, okay. There we go.
Well, it goes perfectly with this moment. Let's see what you think of this. It's basically about the most common causes of miscarriages.
Oh, gosh.
Okay, so there we go. Have a look at that and see what you think.
Most miscarriages actually are the result of a DNA fragmentation from the sperm.
That's never talked about.
No,
we just assume it's something with the girl usually.
Exactly. The time to think about your healthy contribution as a male and the sperm is not the night that you're conceiving. It's about 7 or 8 weeks prior to that.
Oh, yeah?
Because that's how long it takes that sperm to mature. And so that means 7 or 8 weeks before, no binge drinking, no caffeine use, heavy. Moderate's okay, as is moderate alcohol intake, actually.
So caffeine kills sperm?
Caffeine in high concentrations is toxic. Yeah,
Wow.
It's toxic to sperm. You don't want to be a slob. If your hormone levels are out of balance, the testes are dependent on a certain concentration of testosterone within the testicle, not just circulating. And if that gets impaired, then you're in trouble. But it's a long time ago. It's not when you think it is. And most guys don't think about their contribution.
Okay, so what do you think about that? So his point is that men do actually contribute to miscarriages, and then part of that is due to DNA fragmentation in the sperm. So first of all, what is DNA fragmentation?
Good question. DNA fragmentation is whereby in the sperm, what is unique is that the sperm is really the tiniest cell in the human body, and the eggs are largest. So which is why it's always so fascinating to me to understand these two very unique cells come together and a new life is formed. And in the sperm itself, in the little head of the sperm, its DNA is all tightly wound together. So it's almost very hard to break it. But if there's insults, or the sperm undergoes a lot of what we say oxidative stress, it causes that DNA to become brittle and breaks.
Okay.
And when it breaks, it's a sign that, this DNA are not the best quality. And there are chances of repairing the damage that's happened from whatever insults they are prone to, for example, smoking, excessive alcohol, excessive oxidative stress, chemicals, extreme heat, this could all cause that DNA quality to be very poor.
Okay.
And so even if they try, even though they move at Superman speed, and manage to fertilize an egg, that DNA quality is going to affect ultimately fertilization and the embryo that's going to form.
Great. Okay.
And that repair mechanism may translate on to further problems later on.
Understood.
And as the embryo develops. So
what would you say is the most important factor in causes of miscarriage? Is it more the egg quality, or is it the sperm quality, or is it both, or do we not know?
I think we do know the answer. I think with maternal aging, which is as the age of women gets older, we do know that a lot of time eggs are very important in terms of guaranteeing a healthy embryo. And so with the aging process, the eggs get poorer quality, and that really causes a lot of miscarriages. But men's contribution to recurrent miscarriages is a significant event as well.
Interesting.
And I think that both are now as equally important as I see it, that, we just shouldn't blame either one of them, because both should improve their general health such that, their gametes hopefully are healthier, so that when they try to conceive again, hopefully things will be much, much better.
Is there evidence that if you take a man's semen parameters, say if he has undesirable semen parameters, you overhaul his lifestyle and repeat the semen test, that there can be some improvement in it?
Oh yes, you can be very surprised.
Really?
Yes. And because spermatogenesis in men happen every 70 to 90 days, whatever a man does in that 8 weeks could make a huge difference to the next batch of sperm he produces.
Right.
So as simple as just a man stopping to smoke, getting on supplements, and dish those very tight, sexy underwear that keeps his jewels too hot.
Yes.
I think those lifestyle changes can really make a difference to the sperm quality.
Yeah.
And I want to give one example. Men love to be macho. They like to be muscular and physique, and but if they take too much of adulterated products,
Yes.
which I don't know, that could directly affect the sperm count, because there could be adulterated with steroids, for example.
Yes.
And there were examples where men who are so bulky and big, and then when you did semen analysis, just tell them, I'm sorry, sir, but your sperm count isn't great. And you ask them, do you take any other things? And you measure your male hormones.
Yeah, I was going to say.
And they're like, you are definitely, whatever you're taking is definitely doing something to your male hormones.
Yes.
And I agree with what the other person on the video was saying, that, the testosterone in the testes must be of normal levels to facilitate and enhance sperm production.
Yes.
Because anything that you take outside the man's body, whether it's it testosterone that you're taking outside that what the body is naturally producing, the body may read as, okay, I have enough testosterone, testes don't need to work.
Exactly.
And that's where the problem starts.
Yes.
Because then without intratesticular testosterone being formed or at very low levels, sperm production gets into trouble.
And that's exactly what I was going to ask you about, because we talked before about Klinefelters and kind of true andropause and that needing testosterone replacement. But I think, again, on social media, there's lots of men who have started to take testosterone in their 40s. Maybe they've been tested and said that their testosterone levels are slightly lower, but I don't think a lot of them are getting the information that actually this can have an appreciable reduction in your sperm quality.
Yes.
And that's what you're saying there.
Yes, absolutely. And I think important is, when do they get their testosterone levels measured? So who knows when the doctors call them to come in to get their testosterone measured, because testosterone levels fluctuate throughout the day.
Yeah. So
it's usually highest in the morning, hence the morning erections, and all those couples who are saying, oh, we start with the early, that's all because testosterone levels physiologically is at its peak early in the day.
Got it.
And so the testosterone must be measured in the morning.
Right.
And if that is truly low, I should repeat again and sort of correlate with the men's, symptoms and signs. And importantly, we should check the semen analysis again.
Yes.
And ask him point blank, do you still yearn for fertility?
Yeah.
Are you going to get a partner that you will want to have a family with?
Yeah.
Because if you are, and if you really need testosterone, then that may not be your real treatment that you need. Because once you're on testosterone replacement, your sperm production is definitely going to be
And is there
suffering.
any way to get that back again? So if a man has been on that for a while, but then thinks, oh, actually, I would like a baby now, is there any way to recover that?
If it's not for too long.
Okay.
Because it would take time.
Yeah.
Once you suppress the system too long, over long,
Yeah.
it's very hard for the system to bounce back again.
Got it.
It's possible, but it takes time. And also, those cells that produce testosterone, whether are they still normally functioning, or they have now become so used or so wasted that they fail to respond anymore to the normal triggers.
Got it.
Yeah.
Very quickly, can we talk about unexplained fertility?
Oh.
Because I think this can be really, really tricky for patients when they're coming in, they haven't been able to get pregnant, they're very upset, and you've done all of the tests, but nothing can be found. And that can be really, really tricky. How do you kind of explain that to couples? And what are the chances of them conceiving if they were to give it more time?
Now, for these couples, I would say, I'm sorry. The system fails you.
Yeah.
Because technology isn't able to find out every single cause of fertility. We now delve into genetics, we delve into newer tests, but again, is it for every couple? I don't think so. So I think what they really need is a listening ear and tender loving care, which we always forgot.
Yeah.
Same as couples who undergo recurrent miscarriages as well.
Yeah.
I think that support, the emotional support, sometimes can be really tough.
Yeah. And that's evidence-based, isn't it? So there is evidence that
Yes.
actually emotional support in a woman who's having recurrent
Precisely.
miscarriages actually makes a difference.
Yes.
Yeah.
Just by seeing you a few more times.
Yeah.
You know, they just feel that they are cared for and that,
Yeah.
you know, things will, you know, go on. Or like if anything happen, I know I have someone to look out. You know. Same for this couple's unexplained fertility. I mean, again, the fertility guidelines are now getting there. They are also advising a lot based on the woman's age itself. So if a woman is, of course, above 35, then maybe not wait too long because we know we're about egg quality and all these things, factors coming in as well.
Yeah.
So if she really wants to have a pregnancy, then we should move her on in her journey if that's what she prefers.
Yeah.
But if she's a younger woman, then what we would always suggest is that, you know, perhaps we could try simpler methods and perhaps even you know, that one some of the professors were saying, do your homework.
Yeah.
You know, just enjoy your homework.
Yeah. Yeah.
You know, do it properly, do it happily, with lots of love. Maybe you'll get there.
Yes.
And to share a story, I literally have a couple who's like that, who went through IVF because they have lost a few, you know, pregnancies and they are really, really, you know, very, very disappointed, very depressed. But in the end, before I could use IVF to help them to conceive, she conceived naturally on her own.
Amazing.
And I delivered the little one.
Oh, amazing. So there absolutely is hope. Even if
There
science
is.
haven't given you an answer as to why, it can still happen.
It absolutely can happen.
Yeah. Yeah. Okay. So I think we're coming to the end of the podcast now. Thank you so much. I think we've covered so much and I think that's going to be super helpful for women. I just wanted to talk about your research into reducing or kind of looking into the reasons about reproductive aging and how we reverse that. How far along are we on that?
We still need some more time. We need some more funding. That's the truth.
Yeah.
But I think there are interesting insights already. And I think what we're doing now, especially very human focused, and hopefully we could, you know, move on to the bench and really find some useful molecules and mechanisms. You know, to really, really, well, what I really feel is that we need more diagnostics. We need quality biomarkers that could let me just triage a woman. I'm sorry to use that word, but help me screen her better.
Yeah.
You know, so that I could have a more accurate sense of how I tell, you know, your ovaries are actually doing really well. You are perhaps doing everything right for it, and perhaps you have good genetics to cover it, but please continue this.
Yeah.
And perhaps you have a few more years to think about what you want to do next. You know, I hope we'll reach that soon, the next 5 years, I hope.
Yeah.
Because we're looking at some interesting molecules and I hope we could get there, you know, at least a couple of them, you know, to be really helpful for women out there.
Yeah.
Because I think if we can stratify women more accurately and not just based on a couple of markers, and her entire life, you know, has to depend on those two, and she's like, oh my, do I just have to listen to them saying this because of this?
Yeah.
You know, I want to give them more options so that they know where they truly are.
Yeah.
And also, once we know what these molecules are, we could actually, you know, have interventions on the next step forwards.
Can I show you one more video?
Oh, wow. Okay.
One more video. Just thoughts. So this is more of a philosophical video.
I said that sex is going to be for fun and for pleasure, but most likely in a generation from now, when couples want to have kids, most likely they're going to be using artificial reproductive technique. You'll have frozen eggs.
Wait, are you saying that we won't have sex to have children?
I'm sure my 2-year-old will ask me, Mom, Dad, you had unprotected intercourse? What about chromosomal abnormalities, miscarriages, twins? What were you doing? Russian roulette.
Oh, gosh.
That's a rather depressing view, isn't it?
Very sad.
What do you think, Professor Huang? Are we still going to be having sex in 10 years' time?
Well, you know, the other part of practice that I do is actually sexual dysfunction. And really, I tell couples all the time, if you love each other, please make love.
Yeah.
And I think sex is so important. And there's this point in time when I actually was sharing that how human sexual anatomy, or how whoever the creator was, that made human anatomy meant to enjoy sex.
Yeah.
There's enough evidence that having orgasms actually releases endorphins, which are feel-good hormones. and that relaxes you, that calms you down, and that's why you sleep better after orgasms and sex.
Amazing.
So
Okay.
there's so much positive things about intimacy that we should not, just put it aside.
Yeah.
And I always tell the couples that, when a child is made of love, that child will have all the love in the world
Yeah.
that a child ever needs.
Okay. So we don't have to worry that everyone is going to be having IVF
No,
in the
please
future.
don't.
You don't think that's the future for us?
I don't want that future.
It feels a bit soulless, doesn't
No,
it?
I don't want that future. Sorry.
Do you have any last messages for anyone listening that's trying to conceive? What will your takeaway messages be?
I want to tell them that, we need to seek out some answers. So get those answers early. And if there's anything that you're unsure about, do ask them and ask them truthfully so that you have the true picture.
Yeah.
And don't give up. There are a lot of ways, where families are created. And as long as you don't give up and love yourself, you'll surely get there.
Amazing. Thank you so much for your time today. It's been really, really helpful. I think we've covered so much. I could easily get you back to talk about more. We could talk about menopause and how to give birth and all sorts of things. So I definitely want to get you birth.
There's a lot to talk about.
There's a lot to talk about, but thank you so much. I think that's been really, really helpful.
Thank you for the invitation.
And that's it for me. I'm Dr. Natalie Hutchins for the Women's Handbook Podcast.